Thank you for the opportunity to come here to Brazil and speak about something that's very dear to my heart, and that is treating patients with schizophrenia and chronic psychosis. It's something that I deal with on a daily basis. I run a 24-bed inpatient unit that focuses on the research and evaluation of patients with chronic mental disorders, particularly schizophrenia and schizoaffective disorder. We also have patients with bipolar disorder as well. And today I'll be talking about actually one particular molecule, and that is quetiapine, and talking about the evidence that supports its use in the treatment of patients with schizophrenia and bipolar disorder. But I'll use a historical perspective. And my first exposure in prescribing quetiapine was actually before the drug was released commercially. We were involved in a clinical trial prior to registration of patients with refractory psychosis. And we would compare, it was a double-blind randomized clinical trial comparing quetiapine with a first-generation antipsychotic. And we were dosing quetiapine blindly up to 750 milligrams a day. And I think pretty much every patient that was enrolled in the study, we went up to the maximum dose in the flexible range, no matter what they were randomized to. So you can imagine my surprise when quetiapine was first launched in the United States in 1997 that we were told to prescribe it to a dose of 300 milligrams a day. This didn't make any sense to us, and we saw that this drug was not being used very much for a couple of years. The 300 milligram dose was actually far too low. And over time, we've gotten additional clinical experience on how to dose this drug properly. So I'm going to go over the historical perspective of using quetiapine and using slides that were used years ago to promote quetiapine and how those have changed as well. This is my disclosure. I have relationships with a number of different companies, some of them very large, some of them very small. What we depend on our research unit is funding from the government, from national agencies, and contracts with pharmaceutical companies so that we can do all the research we want to be able to do. So the evolution of quetiapine is kind of interesting. It was released in the United States in 1997 for the treatment of schizophrenia. And there were subsequent approvals for other indications, notably bipolar mania and then bipolar depression. The extended release formulation then came afterwards, and that also got approved for the same indications. There are other indications that the Food and Drug Administration has entertained. A decision has not been finalized, but in some countries it's approved for other disease states as well. But what has really changed and has made an impact, and why quetiapine is actually used a lot, is we know how to use it. We know how to dose it. But that did not happen overnight. This is an old slide of a promotional material that described how patients with schizophrenia can be maintained with quetiapine in open-label extensions to double-blind clinical trials. And it demonstrated that improvement occurs over time. Now, I see this as somewhat, reassuring that patients improve acutely, and provided they remain adherent to medication, they continue to show improvements slowly but surely in positive and negative symptoms. What is in small print at the bottom of the slide is the mean dose of about 500 milligrams a day. Now, this is quite striking because this was used in promotional materials when the other discussion centered around, well, we need to dose quetiapine to a target of 300 or 400 milligrams a day. Yet, the open-label extension trials told us, well, when you maintain someone on quetiapine, you actually dose it somewhat higher. Quetiapine, looking backwards, actually is an efficacious drug. Compared to placebo, it shows superiority. This superiority in the treatment of psychosis can be seen at the week 1 time point. This is also very reassuring, but we also need to know how long to use it, at what dose, and so on. Other issues that have come up is what about other disease states? And sure enough, other studies were done. Now, the dosing of quetiapine in product labeling is still kind of restrictive. In the United States, if you read the product label, it still tells us to start at a low dose on day 1 and to titrate over several days to a target of 300 to 400. The Brazilian instructions are actually a little different and suggest 600 milligrams a day is quite reasonable on day 6, and when appropriate, you can go up to 800. In the US, this language is not so clear, and that led to really a very slow adoption of quetiapine until more clinical experience was accumulated. Now, the extended release formulation, different. It's different in the instructions and how to dose it and how to titrate it. Let's take another step backwards and take a look at how we've used quetiapine in the real world. And my real world is a state hospital. And in the New York State hospital system, we have 16 of them. 16 state hospitals, 5,000 beds, and about 10,000 patients treated each year. One of the things we can do is look at all the prescriptions written for each of these patients, looking at which antipsychotics are prescribed, which anticonvulsants, if lithium is prescribed, what combinations are used, what doses of each are used. And we've been using this database for a variety of these observational retrospective analyses. One of them, which was published as the cover story in the Journal of Clinical Psychiatry a few years ago, looked at dosing of quetiapine in our real world of the state hospital system and how it differed from the registration studies, how it differed from AstraZeneca's initial recommendation that we need to dose it to a target of 300 to 400. Now remember, our own personal experience, even before the product was launched, that we would dose it higher in that clinical trial with more refractory patients. So let's take a look on how state hospital psychiatrists prescribe quetiapine over the years. And we can look at the percentage of patients receiving quetiapine at doses above 500 milligrams a day, considered at that time a high dose, or 750 milligrams a day, considered at that time the top dose. It turns out that over the years, from 1998 to 2004, at the time the study was actually completed, the percentage of patients on quetiapine receiving a dose over 500 was about 50%. This didn't happen overnight, it took time, but this tells me that psychiatrists in the real world of treating patients didn't go by titrating to 300 or 400 and stopping. They continued on to over 500. In fact, about a third of the patients actually received quetiapine off-label at a dose exceeding the product label maximum recommendation. An off-label use of a drug at this dose so early in time tells me that perhaps the initial studies done with quetiapine were done with doses that were simply too low to control the psychopathology of the patients. Let's shift gears for a minute and now go over to the evidence that supports its use in bipolar disorder. This slide here shows the studies done for patients who've been stabilized on quetiapine. They all have bipolar disorder. What would happen if they were randomized to continue quetiapine or to receive placebo? Now, as you would guess, these patients would relapse if they were randomized to placebo, and in fact they did. They relapsed at a higher rate than those who were maintained on quetiapine. Now you wonder why I would be showing this, because it's fairly obvious. Someone is doing well on a medicine, If you randomize them to continue that medicine, they're going to do better than if you randomize them to placebo. But unfortunately, this type of study is still necessary in order to get approval from regulatory agencies for maintenance indications. So this does show evidence to support the use of quetiapine, actually as a monotherapy, something that isn't in the label as such, for maintenance of response. We can also look at studies that have been done comparing quetiapine with other mood stabilizers, in this case lithium. And we can compare quetiapine versus lithium versus placebo over a long period of time to see if there's any differences in relapse rates. As you would expect, those randomized to placebo in red had higher rates of relapse. They could not be maintained for very long periods of time. This is common sense. If you have someone who's stable or stabilized on a regimen, if they're given placebo, they're going to deteriorate faster than if they continue to receive something that actually helps them. And here, quetiapine and lithium had very similar trajectories in terms of maintaining response. Now, the actual indication in the United States for quetiapine in maintenance of bipolar disorder is adjunctively with lithium or divalproex. And this is because of the registration study that was done earlier in time and submitted to the regulatory authorities for the purposes of getting this indication. And here, quite clearly, patients who are maintained on a combination of quetiapine or lithium do better than if they were randomized to placebo plus lithium or divalproex. Again, common sense. In any of these study designs, if you recruit patients, stabilize them on a regimen, and then randomize them to stop that regimen, they're going to deteriorate. The reason for these types of studies is to garner regulatory approval for the indication, in this case, maintenance of bipolar disorder. Now let's bring dosing back into the discussion. With schizophrenia, with the immediate release formulation of quetiapine, the label says start low, go slow, go to 400. The Brazilian label suggests going a little higher explicitly. The bipolar mania suggestions actually start higher, go up a little faster. Now, why would the labeling language be different for bipolar mania? Simply put, we learned from our mistakes. It became obvious that the titration of quetiapine earlier on in the early studies was too conservative. The bipolar mania studies were designed somewhat later and learned from that mistake, and the titration schedule was somewhat more aggressive. In contrast, bipolar depression continued with the start low, go slow, and again, this is common sense. If you have someone with depression, you don't want to overwhelm them with a drug that can sedate them perhaps more than they would desire. Perhaps they're already slowed down from their depression. Giving them a highly sedating drug at a high dose early on probably does not make sense. So here we have to struggle with the dosing for schizophrenia for immediate release quetiapine was wrong. The dosing for bipolar mania sounds more correct. And the dosing for bipolar depression is correct but different from the other two. So it makes quetiapine a little difficult to explain simply with dosing. It's going to be simplified with the extended release formulation. We've seen that quetiapine immediate release is efficacious. Clinical trials in schizophrenia, bipolar mania, bipolar maintenance all show efficacy. What about the extended release formulation, and how does dosing differ? Well, with schizophrenia, for me, this was the biggest news. The efficacy was shown and established with the range of 400 to 800 milligrams a day, once daily dosing. But the most important aspect is the initiation at 300 milligrams a day. Now, as a clinician, I want to start pretty aggressively with a patient who's acutely psychotic. With the extended release formulation, the study design was actually with a higher dose in mind on day 1. Moreover, you can go to 600 milligrams on day 2 and actually 800 milligrams on day 3. Think of that. 300 on day 1, 600 on day 2, 800 on day 3. Compare that with the immediate release recommendations of starting kind of slow, kind of going to 400 by day 4, maybe 600 by day 6, and maybe one day on 800. That's far too low and too slow for patients who are acutely psychotic. But that's the way the original immediate release studies were designed. That's how the drug has to be promoted. The extended release formulation, those studies were designed differently. People learn from their mistakes, and people who design studies are no different, and learned that perhaps a better way to go is to start higher, go up faster. And for me, that was very interesting, because now I can tell clinicians, you can start at 300 on day 1, go to 600 on day 2, and still be on label. The tolerability is the same as the IR and the immediate release, and we'll go over that in a moment. Now, what makes the extended release formulation different? This is a very high-tech diagram taken with a sophisticated imaging machine showing what a man really looks like and his internal organs. Anyhow, this is the pill of the extended release formulation. It consists of a hard core of drug surrounded by a gel layer. And what happens is that the pill is swallowed, and once swallowed, water starts to enter the hydrated gel layer. Water channels are created, and the molecules come out. And if you look carefully, this sophisticated image shows you what the molecules actually look like. That's a bit of a joke. They don't really look like that. It's an artist's depiction. Anyhow, the consequences of this slow release from the hard core over a period of about a day is that it's a slower release that occurs with a lower maximum concentration in the plasma. This is the pharmacokinetic profiles of immediate release and extended release. The immediate release formulation has a rapid absorption, a very high maximum concentration occurring in a very short period to maximum concentration. So Tmax is short, Cmax is high. The extended release formulation, Cmax is lower and Tmax is longer. The immediate consequence for your patient is that if they're expecting to be sedated immediately, it's not going to happen. So if they're used to taking quetiapine in order to help them sleep, in addition to helping their psychosis or their mania or their depression, they need to take it earlier. The extended release needs to be taken earlier in order to maximize the sedative effect, if you want to use it that way. When we look at the dosing with quetiapine in the evening, 3 to 4 hours before bedtime, the maximum concentration will occur at bedtime. So it's different. You don't give it an hour before bedtime, you give it 3 to 4 hours before bedtime. The other aspect of the extended release formulation is that it can't be cut, can't be chewed, can't be ground up into a powder. Otherwise, no more hardcore for it to be slowly disintegrating over time. This, by far, is the biggest news. 300 on day 1, 600 on day 2, on-label schizophrenia makes it easy. If this had been the message in 1997, the use of quetiapine would have been much faster on the uptake than it was. It wouldn't have taken 3-4 years to sort of figure out that you really need to dose this drug higher. Now I'm going to show you evidence that actually supports this. I'm going to show you the results of the registration trial that compared 3 different fixed doses of extended-release quetiapine with 1 fixed dose of immediate-release quetiapine and placebo. The idea here was simply to demonstrate that extended release was superior to placebo. The immediate release was an active control. But whenever you have a fixed-dose study, it can tell you something about the dose response. This was not the design or intent of the trial, but we can still get that information. We just have to look a little harder. This is the titration schedule. Every patient on the extended release started at 300. Those who went to 400 got there on day 2. Those who were randomized to 600 got there on day 2 as well. Those that were randomized to 800 got there on day 3. And the guys and girls who were randomized to the immediate release formulation got to 400 over time, just like the label. It turns out that all patients, no matter what they were randomized to, got better. Patients randomized to placebo also got better. But you know, placebo doesn't mean no treatment. These patients were all enrolled in a protocol where someone would talk to them on a regular basis, provide them with some way of feeding, housing, reassurance, support, monetary compensation. That all helps. But the response to placebo kind of stops after day 21. After 3 weeks, patients randomized to placebo didn't continue to get better. Those randomized to active drug continue to get better. What is kind of interesting here is, when did separation from placebo occur? Well, it occurred earlier for the higher doses of quetiapine extended release. Those randomized to 800 milligrams a day separated it from placebo earlier than those randomized to the lower doses. So that tells me that dosing probably matters. If we take a look at the subscales of the positive and negative syndrome scale, and I should mention, this, I assume that you all could read, right? You can all read, right? The y-axis is the positive and negative syndrome scale, standard scale for psychopathology, reduction in time. What about the subscales? Positive, negative, general psychopathology. What were the improvements? Were they separating from placebo? If so, did all doses separate from placebo? Well, this is where it gets interesting again. For positive symptoms, positive subscale scores, and for general psychopathology subscale scores, all active drug arms separated from placebo. However, for the negative subscale, only the higher doses of quetiapine extended release separated from placebo. So maybe higher is better. If we take a look at the aggression and hostility cluster, yes, active drug separates from placebo. Higher doses separate earlier from placebo. So this is improvement in aggression and hostility, something that we care a great deal about in our patients with acute psychoses. What about depression? We also care about depression, as we heard in the prior presentations in our patients with schizophrenia. Here, only the higher doses of quetiapine extended release separated from placebo on this particular measure. So we see a pattern emerge. In general, sure, 400, 600, and 800 all are efficacious in the treatment of schizophrenia. When you look at how fast response occurs or how fast separation from placebo occurs, and whether or not all subscales and factors are ameliorated, and it seems that only the higher doses do that. Before I move on to the maintenance treatment of schizophrenia, just want to mention that we're doing a study now. It's off-label, but it compares our usual dose of quetiapine that we use today, 600, with an off-label use of 1,200. And we're comparing these two groups of patients, double-blind. It's a randomized study. Patients first initially have to fail 600 for 4 weeks. If they fail, that is, don't get better after 4 weeks of 600, they're randomized to either continue 600 for another 8 weeks or go to 1,200, an off-label dose. And that will help answer the question, is there a true dose response? And does it make a difference going higher for patients who don't respond to a lower dose? I think we all do this clinically, but it's never been adequately tested in a randomized controlled trial. Let's move on now to the maintenance treatment of schizophrenia. As you might have already guessed, the way regulatory agencies approve an indication like this is really by a study that randomizes stabilized patients to either continue their active treatment or to go to placebo. That's exactly what was done. This is a double-blind, randomized clinical trial of patients who are stabilized on quetiapine extended release, then randomized to receive either the drug that they were stabilized on at the dose they were stabilized on, or to placebo. You know the answer to the question, which group did better. I'll show you that answer anyway in the next slide, but I want to point out the dose range, 400 to 800. The modal dose, however, was 800 milligrams a day. So clinicians enrolling patients in this study and stabilizing them on extended release prior to randomization, the modal dose was 800 milligrams a day. That's what clinicians did to stabilize their patients. As you might have guessed, those who were maintained on drug relapse less often than those randomized to placebo. What about extended release quetiapine in mania and depression and maintenance? Well, let me put this into some context for you. In the United States, we have many, many options for the treatment of bipolar mania. We have fewer options for bipolar maintenance, and we have very, very few options for bipolar depression. In fact, there are only 2 approved indications in the U.S. for bipolar depression. 2 drugs. Quetiapine as a monotherapy and olanzapine fluoxetine combination. That's it in terms of the indication. So quetiapine actually fits in quite well. Bipolar depression, bipolar mania, bipolar maintenance in conjunction with lithium or divalproex. Now you may be wondering, why would quetiapine as a monotherapy actually work? It's a dopamine D2 blocking agent. It's a serotonin 5-HT2A blocking agent. Why would it work for depression? Well, it turns out that there is a metabolite of quetiapine called norquetiapine. And norquetiapine actually has activity at a site called the norepinephrine transporter. It increases norepinephrine at the synapse. And we know that antidepressants can work by either increasing serotonin or norepinephrine or both at the synapse. Well, norquetiapine can do this. And this is one possible explanation as to why the monotherapy of quetiapine actually works in the treatment of bipolar depression. Not by D2 antagonism, not by 5-HT2A antagonism, but perhaps by the norepinephrine transporter through the norquetiapine metabolite. That's one thought. Bipolar depression, bipolar mania, and mixed. I showed you a slide a few slides ago about dosing. The dosing for bipolar mania, day 1, 300, day 2, 600. If it sounds familiar, it should be, because that's the same instruction as for schizophrenia. 300 on day 1, you can go to 600 on day 2. You can go to 800 on day 3 as well. So this is simplified. It's a simple message now. Bipolar mania, acute schizophrenia, start at 300, go to 600, and I like to go to 800. The evidence tells me that I should. Bipolar depression, a different story. You want to start lower, go slower, because these patients are different in terms of how they'll tolerate sedation. Now, the indication for mania stem from the original immediate release studies and also a 3-week multi-center double-blind study done with the extended release formulation. It was done in the United States at 48 centers, and flexibly dosed quetiapine, 400 to 800, works. No one should be surprised. Immediate release works. Why shouldn't extended release? Bipolar depression, very similar studies were done, as was done for the immediate release formulation. The primary objective in the study was to compare quetiapine extended release versus placebo. And the primary outcome measure was the Montgomery-Asberg Depression Rating Scale. To no one's surprise, quetiapine 300 separated from placebo, separated as early as week 1. It works. The immediate release formulation also tested 600. 600 was unnecessary because 300 works just as well. Does everyone need 300 and only 300? No. Some may need a little less. Some may need a little more. If you know how to use the immediate release formulation of quetiapine, you know how to use the extended release formulation. The adverse event profile is the same. You can expect sedation, dry mouth, somnolence, constipation, just like the immediate release formulation. This is true for bipolar mania. This is true for bipolar depression. This is true for schizophrenia. There is one slight difference, and that is the immediate perception of the drug. For some patients, they may not feel that acute sedation that occurs about an hour after taking immediate release quetiapine. Other than that, it's the same. Now, extended release quetiapine is indicated and approved for acute depressive episodes associated with bipolar disorder, acute or mixed episodes associated with bipolar 1 as monotherapy and as adjunct to lithium or divalproex, and maintenance as adjunct to lithium or divalproex, and of course, for schizophrenia. The immediate release formulation has very similar indications, just slight difference of not including mixed episodes of bipolar disorder, only because the original studies done long ago didn't include those patients. The bottom line, there are multiple indications for the extended release formulation and conventional quetiapine. Some of these indications do differ from country to country. There are similar tolerability profiles between XR and IR. If you know how to use XR or XRO in Brazil, you know how to use IR. The only difference that may make a difference for some patients, and you need to tell them about that if they're used to taking IR, is short-term differences with Cmax and Tmax that I had described. The biggest difference and biggest impact in my eyes is now the company can go out there and tell clinicians on label, per official regulatory approval, that you start at 300 on day 1, can go to 600 on day 2, and we don't have to worry that patients are being underdosed. Now, if you have any additional questions, I know I only talked about quetiapine in this presentation. That's the focus. I do have a lot of information about other antipsychotics and about dosing and about medical decision making. That's my principal area of interest. You can always email me. I'd be happy to answer your emails. No one emails me. It's lonely. Please email. And thank you very much for your attention.